Hey, good morning, everyone. My name is Dr. Claire Wright from Hamilton Eye Institute. I'm going to go ahead and share my screen, and I'm going to be discussing today glaucoma in the myopic eye, diagnosis and management tips. So I have no financial disclosures. So these are our lecture objectives, and one of the first one will be to detail optic nerve features in the myopic eye. We'll also describe common retinal nerve fiber layer imaging and visual field findings in the myopic eye. And then we'll try our best to understand the nuances of glaucoma management in highly myopic patients. So why should we care about this relationship between glaucoma and myopia? So this is a review for many of us eye care providers, but glaucoma is the leading cause of irreversible blindness worldwide, with 67 million people affected and 10% of whom are blind. Glaucoma in the United States, where I'm lecturing from, affects 2.2 million people, and it is the second leading cause of irreversible vision loss in people over 40 years of age, with the first being age-related macular degeneration. Now, the incidence of glaucoma is increased, which we'll discuss in this lecture, in patients with greater than -6 diopters of myopia. And myopia is actually increasing worldwide. There's a number of studies, especially Chinese-based studies, that have demonstrated very clear, rapidly increasing rates of myopia. And it's postulated that this may be to increase time spent indoors, perhaps increased screen time, etc. Now, how do we define high myopia? So the classic definition that you see, I think, most consistently across the ophthalmology literature is axial length greater than 26.5 millimeters and or spherical equivalent greater than -6 diopters. So that's just one of the answers here to my poll questions. Now, this is a related point. In the Western world, at least, there's a fairly high incidence of refractive laser correction for myopia, which further complicates our picture, as in patients, once they're surgically corrected, may not seek regular eye care. And this surgical correction does not mitigate the risk of myopic related complications. So a lot of reasons why we should care about this lecture. So let's talk about myopia as a risk factor for glaucoma. There's a number of studies out there, but I wanted to highlight two in particular. The first being the Blue Mountains Eye Study, which is a cross-sectional population study based in Australia. And this used general estimating equation models to quantify this relationship between myopia and glaucoma. And they found glaucoma is present, incidence is present in 1.5% of eyes without myopia, 4.2% of eyes with low myopia, and 4.4% of eyes with moderate to high myopia. Moving on to the Beijing Eye Study, this was another cross-sectional based population study that used morphological assessments of the optic disc photos, which they defined as optic disc glaucoma, to try to shed light on this relationship between myopia and glaucoma. And they found that in patients with both marked myopia and high myopia, they define this as marked myopia is -6 to -8 diopters and high myopia is greater than -8. These patients had a higher incidence and frequency of optic disc glaucoma than those with moderate myopia, low myopia, emetropia, and hyperopia. So this appears to be a risk factor according to these two large studies. Now, why are myopic eyes predisposed to glaucoma? Are they? Well, there's some theories here that make sense to me and a number of other ophthalmologists in the literature. So the thought is that due to axial elongation in these long myopic eyes, these patients then have thinner lamina cribrosa, which then in turn results in compromised structural support for these nerve fiber layers. Other studies have shown that the shearing forces of scleral tension across this thin lamina cribrosa is increased in myopia. But it's important to keep in mind, highly myopic eyes can be associated with optic nerve head abnormalities that can create diagnostic challenges, which we'll talk about. So let's talk about the optic nerve findings in myopia. So highly myopic nerves can exhibit any or all of the following: nasal insertion of the optic nerve, tilted and or large disc, shallow cup, and then peripapillary findings such as a scleral crescent, wherein you actually see, due to thinning of the axial elongation, you actually see the sclera, as well as peripapillary atrophy. Now, of course, as many of us know, these posterior segment abnormalities can extend beyond the optic nerve with altered fundus pigmentation or increased tessellation, temporal displacement of the superior and inferior nerve fiber layers, posterior staphylomas, myopic macular degeneration, and peripheral retinal abnormalities such as lattice degeneration, holes, tears, etc. So the following slides are a couple photos which demonstrate these kind of just funny looking nerves, to be frank, both in the literature, and I have a couple of my own. So in these patients, I'll just give an example of how I personally would interpret these disc photos. I would describe these as, optic nerves are nasally inserted with appreciable scleral crescent peripapillary atrophy, probably more peripapillary atrophy, although the whitening looks kind of like a scleral crescent. But so nasal nerve insertion, peripapillary atrophy, but not much cupping. But the cups do look a little shallow. So I do my best to describe, but of course I take disc photos in all of my glaucoma patients, not just the ones with funny looking myopic nerves. So let's talk about these photos. Again, how I describe, and this is from a wonderful American Academy of Ophthalmology iNet article. These two photos demonstrate myopic nerves. The left shows nasal insertion with not much cupping, which is great, healthy rim, neuroretinal rim, versus the right image, again, slight nasal insertion with a larger cup and a thinner neuroretinal rim compared with the left. So this is, these are photos that demonstrate kind of the diagnostic quandaries in myopia, but at least these two compared side by side, you can see, okay, there is more appreciable cupping in the right photo than the left photo. Let's talk about these photos. So this is actually a patient of mine that we wrote up for ophthalmology management, who, although the patient did not have glaucoma, had degenerative myopia. So these nerves, that's a significant myopic scleral crescent, 360 around this nerve. Speaking of the nerve, those nerves, really difficult to ascertain that cup to disc ratio. And that's how I basically put what I put in my note. If the cup is so shallow that I can't really even make out the borders of the neuroretinal rim, I just don't even quantify a cup to disc ratio and just say poorly discernible cup to disc ratio. So these particular optic nerves are pretty impressive for myopia and associated myopic nerve findings. So thankfully the patient was not being treated for, and I don't think had glaucoma, but had a couple other issues, including myopic maculopathy. So just to continue our discussion of nerve fiber layer imaging in myopia, this relationship between axial length, spherical equivalent, and nerve fiber layer thickness has been explored. In this 2006 study, these researchers found that the average RNFL score decreases with increasing axial length and spherical equivalent. And this RNFL score was significantly lower in high myopia versus low to moderate myopia. This second study, 2009 study, found similar results, wherein the average decrease of the nerve fiber layer average score decreased by 7 micrometers per 1 millimeter increase in axial length. And then they found that for refractive myopia, this relationship was not as strong. So this makes sense because with axial myopia, you've got stretching of the sclera and thinning, and so that makes sense that with increasing axial length, you have decreased RNFL thickness. So this is just a sample Heidelberg RNFL image of one of my patients that of a patient with myopic nerves that I actually de-escalated treatment for. This patient was deemed to have glaucoma, I think, by a referring provider, sent to me for a second opinion, was on prostaglandin analog. And just looking at these RNFLs, we'll start with the left one. We're not going to get too much into how to interpret a OCT, but what I look at is, I tend to look at, of course, confirming the patient name. I tend to look at the red-free image first, just work my way top to bottom. And image on the left, that's actually a fairly normal looking nerve in terms of, nerve insertion, seems to be good centration of that nerve fiber layer, tracking line. Not too much, peripapillary atrophy, scleral crescent. So looking on down at the kind of global thickness score, it looks okay, fairly normal, unimpressive, which is good. I don't want to be impressed in clinic. The nerve on the left nerve, however, you can see in the red-free image, there's a little bit of nasal insertion, maybe a little bit of tilt. You also see that temporal, either scleral crescent or peripapillary atrophy, that makes you wonder, I wonder if this nerve fiber layer tracking scan is picking up on that as opposed the peripapillary atrophy as opposed to the actual temporal border of the nerve. So I'm kind of suspicious of it as I work my way down, and then I do see, look at the global thickness score. I see some supratemporal thinning. So I'm very hesitant to put all my weight into nerve fiber layer scans in myopic nerves, is the long and short of it. So, well, why is this so? Why can this be so confusing in myopic nerves? Well, it's important to keep in mind that current nerve fiber layer scans, these programmings, the way they work is that they rely on a normative database. That's how you get the green, yellow, red, and it's age related. But oftentimes these normative databases exclude eyes with high refractive error. For instance, the Cirrus HDOCT by Zeiss, their normative database is composed of eyes with the average spherical equivalent of minus 0.82. And this basically can result in a high amount of what we call red disease or false positives in non-glaucomatous myopic eyes, which potentially could be eliminated by incorporating more myopic eyes in this database and result in less over treatment of otherwise healthy eyes. So this study in 2016 actually looked at what it would look like to have a myopic normative database with regards to RNFL imaging. So these researchers, they basically created a normative database of 180 highly myopic eyes with the average spherical equivalent of minus 8 diopters, which were otherwise healthy, no retinal disease, etc. And they evaluated sensitivity and specificity of this normative database by using 46 highly myopic but otherwise healthy eyes and 74 highly myopic glaucomatous eyes. And they evaluated RNFL thickness map of SDOCT. So, and they found that their myopic normative database that they built showed a higher specificity than the standard built-in database without affecting the sensitivity of the test. So I think that's interesting. Again, another example of one of my patients, a Heidelberg RNFL OCT, that this one appears more glaucomatous. You can tell working your way top to bottom that red-free image, there's more cupping there. There's also, peripapillary atrophy or scleral crescent, hard to tell on the red-free image, but which could confound, the RNFL global thickness score. But you can see in this red-free image, there's clearly cupping. So I'm already suspicious for glaucoma being present in this myopic eye before I even get down to looking at the global thickness score and the average score of each of the quadrants of this optic nerve. All right, so we're going to briefly mention visual fields and myopia. Now, high myopia can cause visual field changes. That can be due to either optic nerve irregularities, which we're clearly focusing on in this lecture, or retinal anomalies. So visual field defects that favor myopia over glaucoma include, but are not limited to, temporal field defects that usually respect the midline, as in a tilted disc. Also, enlarged blind spot, and this may be due to peripapillary atrophy or scleral crescent. Now, visual field defects that favor glaucoma in the setting of myopia are kind of the classic visual field defects that we're all familiar with: a nasal step, arcuate scotoma, paracentral scotomas, things like that. So, you keep in the back of your mind when you're interpreting a visual field, okay, this patient's got myopia. It still doesn't really change how I interpret a visual field. If they've got a glaucomatous visual field defect, so well, okay, that's probably glaucoma. I'm not as thrown off in my visual field interpretation than I am in my nerve fiber layer interpretation. Okay, so now this is an example of myopic eyes without glaucoma that can demonstrate visual field abnormalities. Let's briefly talk about disc photos in glaucoma monitoring. I think that disc photos are very valuable, particularly in this setting, because we get less noise. Think about that red disease and RNFL OCTs. Kind of throws you off a little bit. And these disc photos, they're just, it's a picture. It's not, it is what it is. It's not impacted by peripapillary atrophy, scleral crescent, disc tilt, nasal insertion, etc. And I think it can better monitor for change than RNFL. And it's just less confusing for the person interpreting. So I think that you can perhaps better identify increased cupping, new rim notching, an increase in peripapillary atrophy, vascular changes, etc. Now, I actually do, again, I mentioned this before, I do disc photos in all of my glaucoma patients annually, but I also do it if I find a new, say, disc hemorrhage or a new finding. So I also want to hit lightly the management of glaucoma in myopia. So of course, as with all glaucoma, the goal is to lower the intraocular pressure, of course, but there are a few caveats I wanted to bring up. Now, it's very important to keep in mind the risk of hypotony maculopathy with incisional glaucoma surgery, especially in young patients. So this is thought to be due to the thin, stretched out, less rigid sclera. And this can actually occur with numerically normal IOP. Numeric hypotony is less than 5 millimeters of mercury. I've seen hypotony maculopathy, with, say, epithelial folds in the cornea and Descemet's folds with a pressure of 10 to 12. So, we shouldn't be dogmatic with the IOP readings. Now, how can we mitigate this risk of hypotony maculopathy? Well, we can make surgical modifications. In trabeculectomy, this can involve, potentially putting in more than your standard number of scleral sutures in that flap. One of my mentors in fellowship detailed for me how one of her myopic young patients in whom she performed a trabeculectomy put something like 8 sutures, and the patient was still had some hypotony post-operatively. So it's impressive what these patients may require. In tube shunt surgeries, you may need to leave the patient with a higher intraocular pressure than you typically would, at the end of your surgery, leaving perhaps more OVD in the eye. and very low threshold to refill the anterior chamber postoperatively. Now, what about selective laser trabeculoplasty in high myopia? Interestingly, and I need to look into this, I had a patient who in her history had a retinal detachment following her selective laser trabeculoplasty done by another provider, and actually looked in the literature. I don't see any case reports of this, so I'm going to look it up, but I'd be interested to hear if any of my audience has had this issue before. So it's given me pause about recommending SLTs in highly myopic patients. So just something to think about. All right, so now, again, this is the first question. High myopia, how do you define it with regards to axial length and spherical equivalent? I'll give you a few seconds to answer. Great job. All right, the answer is -6 diopters and 26.5 millimeters for spherical equivalent and axial length, the definition of high myopia. Great, I'm so glad most of the audience got that. All right, so which of the following, all of the following nerve features can be seen in high myopia except tilted disc, scleral crescent, peripapillary atrophy, or disc hemorrhage? Yes, excellent. So the answer here is disc hemorrhage. All right, third question. Which of the following statements is false? Optic disc photos are a useful means of monitoring for glaucoma and myopia. RNFL in myopia can be subject to green disease or false negatives. RNFL in myopia can be subject to red disease or false positives. And visual field in myopia in the absence of glaucoma can demonstrate enlarged blind spots. So which of these is false? Okay, all right. So yeah, most of you all still got the answer I think is correct, which is RNFL in myopia can be subject to green disease, and I'm sure, or false negatives. I'm sure some of my very bright audience members will have an example wherein they had a false negative green disease RNFL scan. So I apologize, but I should have made it more absolute. But just going through each of these, I mentioned optic disc photos are a useful means for monitoring for development of or progression of glaucoma. I think optic disc photos are really useful, especially if they're really funny looking. It's good to get that. Red disease, I see that very commonly in RNFL imaging in myopia, wherein perhaps that RNFL nerve fiber layer tracker is picking up on peripapillary atrophy or a scleral crescent instead of the temporal rim of the nerve, thereby saying, flagging this as red when truly it's just not catching the correct area. And then you can see enlarged blind spots in myopic eyes, I think due to peripapillary atrophy or scleral crescent, but I could be wrong, but that is something I've seen in the literature, enlarged blind spots in visual fields. So I just want to review just kind of a couple lecture takeaways here. And so do ask, I didn't get too much into this, I mentioned at the beginning, but do ask patients about refractive history. I ask all my patients about previous ocular surgeries, including lasers, because refractive correction for myopia can impact IOP measurements because it affects the corneal thickness, and it does not mitigate the risk for myopia-related complications. So these patients still with high myopia still need to be counseled on the risk of retinal detachment, et cetera. Now, I also want you all to keep in mind the myopia-related nerve appearance when interpreting visual fields and RNFL scans. Really, the key is monitoring for change. Okay, so you don't expect to get progressive myopic nerve changes in a patient because, if they were born that way, it shouldn't progress. So really, you can repeat these testings, and if there's change, that's suggestive of glaucoma. So if in doubt, kind of pump the brakes, don't treat, but just observe and just watch the patient. Now, I also think that disc photos may be more useful for monitoring for change in myopic eyes with glaucoma than, say, an RNFL scan, which has a lot of noise, and it can be a little confusing. I think it's also important to be judicious with patient selection, always, but especially in myopic eyes when you're deciding on incisional glaucoma surgery due to the risk of hypotony maculopathy. And as with all patients, it's important to take an individualized approach in management. You have to factor in things like age, life expectancy, overall health, status of the fellow eye, socioeconomic factors, ability to follow up. It's complicated. I think, one of the best advice I got as a resident was to not be dogmatic in the management of patients with glaucoma. It's not a one size fits all approach. You have to look at the big picture. So I think the same goes for myopic patients with glaucoma. Now, I wanted to end before we get to the Q&A, I wanted to actually draw attention to this old paper in the literature. This is actually the first paper published about examining the relationship of glaucoma and myopia, at least the first paper I could find, published in 1926, almost 100 years ago. So Arnold Knapp, Dr. Knapp, discussed his observations about, this relationship between myopia and glaucoma. And I wanted to read this first quote from him that's from this paper. Although the diagnosis of glaucoma in these cases is difficult, repeated tonometric and parametric examinations will indicate the line of treatment. I think that is just really sums up well a lot of the things I discussed about. And clearly that advice and suggestion has stood the test of time for nearly 100 years. Watch the patient, repeat testing, and if there's change, treat. And now also in this paper, it's actually a really fascinating paper wherein after maybe about 2 pages of Dr. Knapp's observations, there's several pages of discussion wherein ophthalmologists from around the country wrote in with their observations. And then Dr. Knapp went through each comment individually. And so it's a really fascinating paper, but I wanted to draw attention to this other quote from a Dr. Tyson in New York, which I'll read. It's a little long, but in the cases with high myopia and extensive posterior scleral choroidal changes with moderate cupping and relatively slight increased tension or pressure, it is possible to overlook the glaucomatous conditions. I have recently found records of 2 cases in which this occurred, the previous examinations having been made in the offices of competent ophthalmologists. I think that, unfortunately, I do see this where sometimes, and I forgive the pun, but sometimes as ophthalmologists, we get myopic in our treatment of patients or approach to patients, and we fail to pick up on, things that are outside our tunnel vision. And so, sorry again for the other pun, glaucoma, but, I get second opinions, from other providers or from patients seeking it out where, they have glaucoma and it just so happens that their high myopia kind of just confuses and muddles the picture. So I think that this is a challenge for all of us, but we just have to, be vigilant and do our best to, take care of our patients. So these are my references. I want to thank in particular our photography department, wonderful photographers. And this is my email address should anyone have questions or comments, which I welcome and thank you in advance. But I'm by no means an expert. This is just my observations. I've seen it a lot in my 2 years of practice, a lot of myopic patients with and without glaucoma. And so it's been really interesting to dig into the literature a little bit in preparation for this presentation. Okay, so one question is your thoughts about relevance of Bruch's membrane opening, please. Well, to be honest, I need to do more research into that. I see that come up a lot in, current and more recent glaucoma papers. So to be honest, I need to look into that, but I will put it on my to-do list. But I do have one provider here at Hamilton who I think takes that more into consideration than I do. But to answer your question, I need to look into it. Okay, so let's move on. The role of trend analysis in glaucoma follow-up, especially in suspicious cases under monitoring as glaucoma suspects. So yeah, I think that, we at my institution here in Memphis, we don't have, like, for instance, the RNFL Heidelberg printouts, or some of the Cirrus and Heidelberg scans have a trend analysis report. They had it up in my fellowship, but we don't have it here. I think it could be really useful if you have it at your institution where you can track global thickness scores, average scores of each sector of your nerve scan, to see if there's progression, because, if there's progression, that's probably glaucoma, and you should treat it. So same goes for visual fields. You can print out all your previous fields and kind of look at the mean deviation over time. I think if there's progression that's suggestive of change, then you should treat. So yeah, I think it's highly valuable. Now, another question, does IOP measurement give different results in highly myopic eyes, even though laser vision correction has not been performed? I think that's a great question. I'm not sure, honestly. I wonder if, there's, I don't know, I'm blanking on it now, but there's a newer measurement of the cornea, which some institutions use, which measures basically the shock absorption of the cornea, which is basically a surrogate marker for a shock absorption ability of the optic nerve. And I'm just blanking on the name of it, but that would actually be interesting to look at if that measurement differs for patients with high myopia over emmetropic patients. So I don't know the answer to your question, but I think that would be an interesting thing to look at. So another question, in highly myopic eyes with borderline glaucomatous appearance, how long do you suggest to follow the patient and repeat the exam? So depends on what you mean by borderline. So I have, in our ICD-10 coding in our country, there's high risk open angle glaucoma suspect and low risk open angle glaucoma suspect. So depending on how many risk factors they have, I may see them back in either 6 months or 12 months. So if I'm really suspicious, but I just can't pull the trigger on treating for glaucoma, then I'll have them come back in 6 months and repeat the visual field specifically. I could be wrong, so correct me if I'm wrong, but I believe in this country, you can only repeat for billing purposes an RNFL scan once a year if you want to get reimbursed. So that said, if I'm really concerned and do want to repeat it, I will, and just eat the cost. But I would say for highly suspicious nerves, maybe 6 months, and then for low suspicious, maybe 12 months. Okay, so do you have a cutoff for doing a tube instead of trab at certain axial length or refractive error? No, I try to avoid, as I mentioned, being dogmatic. I do struggle with that, but I base my surgical recommendations based on pressure goals. We don't have bare velts at our institute, so we do have Ahmed clear paths, which are the non-valve. So you get lower pressures with non-valved over valved glaucoma tube shunts, but so it just depends on their pressure goal, also ability to follow up and how far away they live, if they're, so there's a lot of considerations here. I don't do it based on the axial length or spherical equivalent. Okay, so hello, Bangladesh. Okay, so do you believe refractive surgery or cataract surgery could increase the risk of glaucoma in high myopes? I don't think so. I don't have the evidence to quote my response, but I don't think so. I think that refractive surgery in particular just confounds things and perhaps reduces the likelihood of patients following up as appropriate for basically monitoring for other myopia related complications. Cataract surgery, no, high myopes, you have higher risk of peripheral retinal pathology intraoperatively and postoperatively after cataract surgery, but which then could, lead to requiring retinal reattachment surgery, which can then increase the risk of developing glaucoma. But in and of themselves, no, I don't think so. Okay, so how do you differentiate between a myopic cup and glaucomatous cup with fundoscopy? I think I answered that question for the most part in this lecture. Do you treat myopic patients with anti-glaucoma drugs, especially children who present with high tonometric readings, even though they have, say, a cup to disc ratio of about 0.5? No, again, hard to make generalizations. I avoid being dogmatic. I look at each patient individually, but in general, if the patient doesn't have a very suspicious looking cup, depends on a couple of things. If they've got high pressure, I look, of course, at their central corneal thickness, because in many of my particular pediatric patients, which is included in this question, a lot of them have high central corneal thickness. So there's no direct chart that can compare, if your central corneal thickness is this much, then your pressure is this. There's no verified, corrective factor. But I look at the big picture. It basically depends on their pressure readings I'm getting, their central corneal thickness, their visual fields, if I can get them. The other thing, the complicating thing about children is that, these normative databases are done in adults. So you have to interpret those with a grain of salt, because typically that normative database is made up of patients over 18. So the bottom line is I look at the whole picture, and I don't like to commit patients to a lifetime of drops if I can avoid it. So I kind of just take it patient by patient. Good question though. So what is your routine to follow up high myopia patients? Any investigation tips to watch out for? It depends on if they have or have not glaucoma. So it depends on their stage. I generally see my severe glaucoma patients every 3 months for pressure checks and a repeat visual fields about twice a year. Moderate glaucoma patients I see about every 4 to 6 months, and mild 6 to 12 months. So just things to look out for, peripheral retinal pathology. I dilate these patients twice a year, low threshold to refer to my retina colleagues, which thankfully I have down the hall from me, and just serial annual disc photography. All right. And how do you approach highly myopic pediatric glaucoma suspects? Yeah, I think, like I said, it's a case-by-case thing. I look at the central corneal thickness, try to get visual fields if they're old enough and able to stand for that. And I try not to commit patients to, a lifetime of IOP lowering medications. Okay, hi, Ecuador. Let's see. What do you think about the role of ganglion cell analysis in myopic glaucoma? I think, I think that it could be, I think it's confounded by the same things, we talked about as with RNFL OCTs. Just with anomalous nerves, but perhaps in patients with non-myopic maculopathy, looking specifically at the ganglion cell analysis in the macula could be valuable to assess for a progression. Yeah, okay, the ocular hysteresis. Thank you, Lynette. That's what I was thinking of. So that's a shock absorption ability of the cornea, which is a surrogate marker for optic nerve. So I think that would be interesting to look at if there's a difference in patients of ocular hysteresis readings in myopic versus emmetropic patients. So thank you so much. Okay, how do you go about in cases of highly myopic patients with anomalous disc and abnormal visual field but normal IOP? This is like the diagnostic quandary of like my day, more often than I'd like to admit, but essentially, I do serial disc photography, watch for change, so in these repeat visual fields and repeat RNFLs, if you're doing them, I just look for change. And so that's key. So if the pressure is normal, I'm not going to treat, assuming their central corneal thickness is average. And I just basically, I just watch for change on testing that, keeping in mind, the confounding variable of myopia. Okay, once in a while, one may encounter an emmetropic, near emmetropic patient with an unusual looking disc that may look like glaucoma or high myopia. In such cases, I find axial length determination to be helpful, as some of these eyes may have long eyeballs with flat corneas or low powered lenses, which mask the possibility of long eyeballs. I think that's a great idea. That's a great suggestion. Thank you so much, because I have a lot of funny looking nerve patients, and I always ask all of my glaucoma patients what their refraction is, or collect it, and if they're pseudophakic, ask what their refraction was pre-cataract surgery if they know. If they don't know, I ask, hey, were you really nearsighted because your nerves are kind of funny looking? But I think obtaining an axial length could be really useful in answering why their nerve looks funny. So that's great. Thank you so much. Can you talk a little bit more about nasal insertion? I mean, it's just, when you have the nerve, instead of kind of coming in the eye here, and maybe my view, on your view, it's more on the nasal side. I sound a little silly explaining this. The reason why I note it is that it can basically alter how that nerve fiber layer tracking where that nerve fiber layer tracking scan. So it can result in basically red disease, where it artificially picks up, hey, there's thinning here, when really that nerve is just tilted and it's picking up on, say, presence of peripapillary atrophy instead of the neuroretinal rim. So that's why I remark on it, and I take a photo of it. So in Black African populations, glaucoma has a relatively high prevalence. Will you advise we start treatment if we suspect glaucoma and monitor visual fields to know if there's some sort of progression or not? Yeah, that depends on the clinical situation, on everything, like I mentioned, from patient's age, life expectancy, status of the fellow eye, ability to follow up, family history. So you got to look at everything here. When I'm really suspicious and this patient, say, has a strong family history, has a thin central corneal thickness, has high borderline pressures, and maybe is hit or miss about following up, well, yeah, I would go ahead and start that patient on drops, or recommend selective laser trabeculoplasty, depending on how you feel about this, anecdotal story I have about that retinal detachment after SLT. So I would recommend treatment if you're really suspicious and you're concerned about follow-up in particular. So good question. So some patients, their IOP is in the normal range, but the optic disc is a little bit unusual. I'm not sure what the question says, but so does this patient need glaucoma treatment? It just depends. You have to look at everything. The bottom line is, if on repeat testing there's change suggestive of progression, you should treat. That's my opinion. How often should myopes have their pressure checked? I mean, it depends on if you think they have glaucoma or not. I discussed my follow-up for mild, moderate, severe glaucoma, but I generally recommend at least annual follow-ups, or for anyone, but high myope, probably at least biannual, just to ensure that their retina is stable. Good afternoon from Zambia. Thank you. Hello. Let's see. So this question, this person has a patient with a tessellated fundus and a cup to disc ratio of 0.45 with normal pressure. I don't know. I'm not really impressed by that cup to disc ratio, and especially in the setting of normal pressure. I'd probably monitor that patient, but of course you kind of have to look at, everything, testing, et cetera. But based on the cup to disc ratio alone and the normal pressure, okay, I'm not as concerned. What is your opinion about monitoring choroidal vasculature with OCTA, for instance, as it has been shown that choroidal vasculature appears to be more sparse among high myopes? I think that's a really interesting question. I don't know that much about it, and I need to look more into it, but I believe our institution actually is in the process, or has, an OCTA. Shows you how clued in I am to my surroundings. But I think that would be a really interesting area of study or things to look at, and could be a useful means of monitoring for glaucoma, again, as a surrogate marker for nerve disease. If there's, say, increased vascular dropout, I think that could be really interesting. How would you best approach a myopic patient with stubborn IOP that defers medication? Well, so stubborn IOP, you mean kind of borderline high pressure. If the patient, this gets into kind of interpersonal challenges that one may have with patients. I'd probably want to get into why that patient is deferring medication and do a little bit of motivational interviewing, just to see, why they're kind of not preferring to go that route. So I have a couple challenging patients that still for some reason see me, but decline all therapies I recommend. So, which makes me kind of not want to perform, say, surgery on these patients, because I worry about follow-up and compliance. So these patients are really challenging. I don't really have an answer. If you have an answer, let me know. So how good is Zalatan and Miso for management of glaucoma? So I'm not sure what Mesoft is, but Zalatan is a prostaglandin analog. I am a big fan of prostaglandin analogs. My preferred initial treatment in general with glaucoma is recommending prostaglandin, selective laser trabeculoplasty or prostaglandin analogs. So I think the prostaglandin analogs are great. Let's see, how much of pressure should be reduced in normal tension glaucoma cases? So we didn't really get into that, but according to the normal tension glaucoma trial study, that should be reduced by 30% from the highest pressure. So what do you think about brimonidine in the management of normal tension glaucoma? Lots of normal tension glaucoma questions, since it's neuroprotective, especially patients with progressive glaucoma. Yeah, I think brimonidine is great in normal tension glaucoma. We didn't really get into that, but in terms of normal tension glaucoma management, try to lower the pressure by 30% from the highest pressure. Lower threshold to recommend brimonidine since it's got neuroprotective effects. And I still recommend prostaglandin analogs for these patients though. But yeah, lower threshold to start brimonidine, which tends to be my least favorite medication, but in these patients, there is a use for it. Okay, so please talk about the role of laser PI in these cases. Well, we pretty much, I didn't really talk about angle closure glaucoma, in which case laser peripheral iridotomy is the one of the treatment modalities. So there's not really a role for laser PI in open angle glaucomas. So what is your approach to highly myopic glaucoma patients who are pregnant? This is one of my favorite topics. A management of glaucoma and pregnancy. But yeah, it's a challenge. I have a whole other lecture on it that I give to our residents every year, but there's a lot of contraindications to our default glaucoma medications based on very limited literature, since you really can't do tests, you can't do studies on pregnant patients. So safe medication in pregnancy is, I think it's brimonidine. Correct me if I'm wrong, but I need to pull up that lecture. But yeah, these are really challenging patients. The best thing you can do is tide over the pressure as best you can until delivery, and then perhaps consider, surgical options, and your options open up in the postpartum setting. So good question. That's a whole other lecture though, but we're at the end of the Q&A. I just want to thank you all again for your time and attention. And please don't hesitate to reach out to me with any questions or even corrections. I always welcome feedback. So thank you so much again.